with Maria Crispin, who you may know, the computer scientist, and Matt Poor at the back there. And she's going to not tell us about imaging, I found out, but from radiology reports to patient journeys. Hania, thank you.
Thank you so much for your kind introduction and for the invitation. It's an incredible privilege to be here and actually speak at one of these events. And it's so nice to see so many familiar faces here. And thank you so much for coming. So yeah, I wanted to give an update of what I've been up to in my PhD. And well, the title is From Radiology Reports to Patient Journeys. So why do we care about patient journeys? Well, let's think about an example of a patient. So a patient with liver cancer, I work on liver cancer in my PhD. It's supposed to be simple. We know who gets liver cancer, and that's people with chronic liver disease. But the story is actually never that simple. So let's look at this example. It's a real patient. I curated this data from Epic. He was diagnosed with HCC back in 2021 in Lincoln, was referred to Nottingham as a local centre. And then he underwent a resection. He had some more imaging, CT, MRI, but then the cancer recurred. He had another treatment with TAE, and then the cancer recurred yet again, and they had yet another treatment with RFA. And at this point, only they were referred to us, to Addenbrooke's. They went through multiple MDT meetings, and then ultimately they were put on the liver transplant assessment list, and they were actually listed for a transplant, which happened in 2024. They were given a new liver. And what they want to point your attention to is how much data we've collected for this patient throughout their journey. There were multiple scans, the generated reports written by the radiology department. There were pathology reports. There were clinical notes that I'm not even showing here from kind of clinics and inpatient stay, and obviously the MDT notes. And this is a lot of data that we store routinely in Addenbrooke's. But at the moment, we very rarely use this data quantitatively to actually learn something about our patients. And with the kind of things that we might do if we had access to this data would be starting with audit. Just thinking about how do our systems actually work on our patients? Kind of, is our NDT system working the way that it should be? Is the lesion grading working the way that we're expecting it to be? But we can go further. We can think about, are there early predictive markers that we can uncover in this data that we perhaps haven't looked at before? Is there something that happened much earlier in the patient journey that perhaps would have predicted the prognosis for this patient? And lastly, can we reconstruct this accurate patient journey so that we can analyze it as a time series data? I think time series is very often neglected when we collect data manually because it's really hard to do and it's a lot of work. But perhaps that trajectory itself is meaningful and we can learn something from it. So what is the challenge? Well, I'm just showing you two examples of reports. They are MRI liver reports, and I'm not expecting you to read this at all, but you can see the one on the left is much longer. It's nicely structured. All of the variables are reported. So first of all, you can see it's a lot of work to actually put that into a nice Excel spreadsheet so we can analyze it quantitatively. And second of all, it's hard to reconcile that with the other, all of the other reports, which perhaps are much shorter. They have no structures and there's lots of variables that are missing. They're not reported. So we don't actually know if they're absent or perhaps the radiologist didn't comment on it. And as a note, that short report is actually an MDT review. So this is not the full report, but that's all that we have access to because that was done here in Addenbrooke's and the imaging was done elsewhere. Further on, our way of reporting has changed throughout the years. So now we have the LIRAD system for liver lesions reporting, but that was only implemented in 2019. And if we want to analyze this data at scale, we again need to reconcile our current classification system with what was before. It's another challenge. And yet another challenge is obviously the volume of data. I think most of us have done audits before, and we know how much time it takes to curate this data manually. So the cohort that I'm working on is a cohort of 835 liver transplant patients, and that is over 22,000 reports across their patient journeys and more than 3,000 years of follow-up all put together. Now, we cannot possibly do this by hand. So the question arises, can we use some of the new technologies like large language models for this task? Now, there are challenges to that. I already spoke about the challenges that have to do with reports themselves. Heterogeneity, kind of ambiguities, missing data, all that sort of stuff. We're not going to change that. But there's also some challenges that have to do with large language models themselves. So things like, ChatGPT. Are they actually going to give us the format of the answer that we want? Like, they're trained as chatbots. Like, are they going to give us, if we want a number of lesions, are they going to give us an actual number? And second of all, which model should we use? And is it actually good enough? Is it accurate enough for us to trust the result? So that's the big question that we're going to address in this project. Can we use large language models to automatically extract clinical variables from free text reports? Can we go from free text reports into an Excel spreadsheet and actually trust those results? And we're going to answer this question using a smaller calibration data set. So this calibration data set has only 20 patients, but actually over 200, nearly 300 reports, and 31 questions about clinical variables that we're interested in kind of chronic liver disease context. And these were manually created by myself. So this was my kind of manual audit that we're going to compare the LLM answers to. And altogether, that is over 5,000 question answer pairs. So I think we have a decent sample size to assess these models on. Okay, so first of all, can we ensure a reliable output format? Now, let me give you an example of what I mean. Let's say that we're asking the LLM how many LR1 observations are reported. And I'm telling the LLM answer with an integer between 0 and 20. That is often, unfortunately, not enough. As you can see there's an actual answer from an LLM. The model is actually starting to write a sentence. It is going to actually think through the problem and reason with itself before arriving at that final answer. And that's not exactly unexpected. They are trained as chatbots, so they are trained to chat to you on ChatGPT and so on, but that's not what we want for this task. So we found a solution to this, a technique called constraint decoding. Now, this is a snippet of code, which is the way that you implement it. Or what I want you to pay attention to is this highlighted part of 0 to 9. This is us specifying that we want a digit between 0 and 9, or a combination of digits. And now what this program is going to do is look at the output tokens of the LLM. So basically the LLM say, okay, I'm 81% sure that 1 is the answer, and I'm 11% sure that ID is the answer. Now, ID doesn't match up with our pattern. It's not a digit. So the program is going to cross that out. And in this way, we're not actually changing the probability of the output, but we are changing the format that we're going to get. So we're still going to get the most likely answer in the valid format that we pre-specified. And this has worked really, really well for this task. So in the kind of unconstrained prompting, we lost 13% of the questions. They had invalid answer format. And it might not seem like a lot, but amongst 5,000 question answer pairs, it adds up. And the two implementations of constraint decoding that I implemented, they both achieved basically 100% valid outputs. And this is particularly important for some questions over others. So here I'm showing you valid outputs stratified per question. And there was actually one question, one prompt, which didn't achieve any valid answers. So that would be data that would be completely lost if it wasn't for constraint decoding. So this really helped, especially with questions that were a bit more complicated, like counting lesions or quoting dates of events that we're quite interested in. Okay, so we can ensure format, but now is the answer actually correct? And which model should we use to make sure that that answer is correct? Now, I'm not going to go through this in detail, but this is just showing you a bunch of models that I've tested and which model performed best amongst the 31 questions. And something that you can see is that there isn't a clear winner. It's kind of all over the place. So I'm going to go through this a little bit in more detail one by one. And I'm going to start with comparing LLMs to regular expression search. So this gray box here, which actually was the best in 16% of questions. Now, regular expression search is the traditional technique for doing this task. So let's say that we are interested in finding collaterals in our report. We can specify, okay, collaterals with an S or without the X, varices, shunts. If these words are present in the report, then the answer is yes. This is very simple. You can make these patterns as complicated as you want. This does depend on you knowing what's in the report and the likely wording that the radiologists are going to use. But this was kind of the traditional way of doing this for many years. So we were interested in seeing, are we gaining anything by using LLMs over this method? And just to make a point, this is very computationally cheap. So you can run this on your laptop. It's very quick. And it turns out that in half of the questions that we tested, regular expression search was as good as the best LLM. So actually there was no benefit to using an LLM for those particular questions. And it was particularly true for the simpler questions, so kind of presence or absence, like portal hypertension, ascites, collaterals. And I think there's only a number of ways in which a radiologist can describe that. And often, especially in structured reports, it is very clear, kind of collaterals no, collaterals yes. So it was fairly easy to write like a robust pattern. However, in the other half of the questions, LLMs were significantly better than regex. And this was true for a lot of the more interesting questions. For example, counting tasks, how many liver lesions are there? Citing information like days of treatments, like we're very interested in that for patient journeys, and things that require a bit more context. For example, identify liver imaging or identifying study type. So amongst the LLMs, are there ones that are better than others? Well, here I'm comparing a general LLM called Llama and a model called OpenBioLLM. OpenBioLLM is a model that has been fine-tuned on medical data. So it's supposed to work better. It's supposed to have seen more examples of medical documentation. And actually, I'm showing here a snippet of so-called leaderboard of medical models, and it was pretty much up there. It was the top open source one that we could use, and it was performing really well on those benchmarks. But for my task and on our data, we found that actually there was a sample of questions that the general model was better than the medically fine-tuned one. And this was a bit of a surprise, but it was very useful to know this. And it included questions like, is this liver imaging or not, which is quite interesting. And we have a few ideas of kind of why that happens. So further on, we were interested to see whether the size of the model matters. To put things in context, they're all called large language models, but some of them are much bigger than others. So the big model that I'm using here, it's Llama 70B that has 70 billion parameters. You can try to run it on your laptop, but I promise you it runs very slowly and it might crash. It basically needs high performance computing. And we are contrasting it with a smaller version of this model with 8 billion parameters. Now it's still large, but you can actually run it on your Mac. So it is much less computationally expensive. However, what we found was that for the majority of questions, they were equivalent in terms of the performance, but there was a subset of questions where the large model was better. So we found that there was still a benefit of using the larger ones. And one of the questions for which it was true was actually identifying certain types of lesions, which again is quite an important task for our study. Excuse me. Further on, we wanted to gather whether question phrasing or the way that we write the question actually matters. And maybe you have experience with this, with interacting with ChatGPT. I think sometimes the way that we write the prompt really does trigger different results. And more specifically here, we are comparing two scenarios. We are either asking the LLM to count all of the liver lesions altogether, so all of the types of liver lesions that are reported. So that's this kind of white box here. Or we are stratifying it down to particular liver lesions. So we have LR1, LR2, LR3, and so on and so forth. What we found is actually it's much easier to focus on a specific question, on a specific lesion type, and then combine all of the data together rather than asking it to count all of them. And these differences might not be big, but as you add them over so many patients, they do become significant. So it's quite useful to know this. And another example, maybe a little bit more subtle, was whether we should resolve any ambiguity in terms of a feature being reported or absent in one question or over two different questions. So let me explain what I mean. With the example of collaterals, on normal MRI liver, the radiologist would normally report collaterals yes or no, and then it's a clear-cut decision. But there are reports where it's simply, there's no comment about it, it's simply not reported. And sometimes you have the intuition that like, oh, if they were there, they would have reported them. But that's not always true. For example, if it's an MDT review specifically about one liver lesion, they sometimes just wouldn't comment on anything else, right? So you can't necessarily make these assumptions. And that might add noise to your data if you do make these assumptions. So what we tested here is, first of all, a combined question. So are the collaterals present, absent, or not reported? So the LM had to make a judgment about whether that was reported or not. And then we split this into those two sub-questions. So first of all, is there a comment about collaterals? Any comment, yes or no? And second, are they present or are they absent? And actually we found that splitting it into more specific question, again, did improve performance for the model. It does come with a computational cost because you need to prompt twice, but it at least resolved that ambiguity between not present and not reported features. Okay, so overall, comparing all of the models, this is showing you all of the data from all of the experiments that we've run. So it's a bit of a busy slide. But what I want you to focus on is how close they are to the outside of the circle. So the outside of the circle is accuracy of 100%. And that's shown for categorical questions, so like yes or no, or numerical questions, like how many liver lesions are there. And this model here in blue, that's the bigger Llama model, Llama 70B, and that achieved over 90% accuracy for 24 of our tasks. There were some interesting results. For example, the DeepSeek models performed really, really badly, and we again have some ideas about why that happened. But we were able to find, a pipeline that actually worked for our data for these 24 tasks. And then we checked that pipeline on pathology reports and on liver transplant assessment reports. So it's a very similar task, but obviously the questions were different. There were different variables that we would like to extract. And here I'm comparing the bigger Llama model and the smaller Llama model, and the results were very similar. So for most questions, the bigger model was better. There were some questions where performance was poor and was quite interesting. For example, sometimes the pathologist would state the primary etiology of chronic liver disease, but also have a bit of subtlety. Oh, there's actually a bit of iron deposition, or, it's a combination of alcoholic and fatty liver disease. And the LLM wasn't really able to extract that kind of fidelity of information. So we know that we can't really count on it for those questions. And that was true for pathology reports and for liver transplant assessment reports, which was quite interesting. But we concluded that we have a reliable pipeline that we can apply to large-scale data. So that's what we did. Going back to the full cohort of 835 patients, we took the 22,000 reports and we queried them with the 70B Llama model and constraint decoding. And then we made a very, very big Excel spreadsheet. I mean, it's bad if the computer actually takes like 30 seconds to open the Excel spreadsheet. But then we had really nicely curated data that we can do quantitative analysis for. So just to show you what scale of data we're talking about, on this slide, every column is a patient and every row is a variable that we extracted. And obviously, I'm not expecting you to read this, it's very small, but you can start seeing patterns in this data already. So if I zoom in, these patients are ordered by liver cancer or HCC on the left and no HCC on the right. And you can start seeing that, for example, there are more males in the HCC population. They are more likely to be of viral etiology. It's actually quite a striking effect. And they're more likely to be smokers. And this is true for all of the patients that were transplanted in our center over the last decade. So it's really, it should be really robust for population, from population perspective. So can we then analyze this quantitatively? Well, these are the results. So I'm showing you here, again, the same trends, which are statistically significant. So again, male sex, smoking, viral etiology, and diabetes. Now, this is not new information in terms of the biology. Like, we know that this is true, but it tells me that our pipeline is doing what I'm expecting it to do. It tells me that, this is a sanity check. We can replicate very well-known clinical risk factors using a real-world population with an automated pipeline without manual annotations. And this is, really reassuring because and really exciting, because now perhaps we discover new ones that we didn't study and we didn't think about before, and that can inform future research, that can inform, prospective studies. What else can we learn from this data? Well, we can see how things change over time. So what I'm showing here is the chronic liver disease etiology, primary liver etiology, assigned at the liver transplant assessment report. So this is mostly based on the clinical assessment and patient history. We very rarely do biopsies before transplant. And then I'm showing how that's changed at the time of pathology reports. So actually when the liver came out during the transplant and the pathologist could look at it and make a pathological diagnosis. And what you can observe is that most of these reclassifications were between the alcohol-related liver disease and MASLD. Now, I'm not a hepatologist, so I don't make these diagnoses, but we know that the incidence of combined alcohol-related liver disease and MASLD is increasing, and actually there is a new entity now called MET-ARLD. So perhaps some of these patients were actually a combination of factors, not simply one, and we can look at that quantitatively. So perhaps we can start observing new patterns in our institution that we weren't aware of before. And now this is probably the most relevant radiology. So we were interested in seeing how our liver classification actually translates to the ground truth from pathology. So if we classify patients as LR3, LR4, LR5, how many of them actually have liver cancer when the liver comes out and the pathologist can examine it after the transplant. And I'm just going to point to this graph on the right first. So this is the LIRAS classification. As you can see, the LR5 classification at the level of the patient has really, really high specificity, but also 85% sensitivity. And this is a drastic improvement to what was before, which was basically a description of the liver lesion. So previously, if the radiologist said, oh, this is definitely HCC, it was very specific, but it was only 57% sensitive. And then they were like, oh, it's probable HCC, their sensitivity is higher. But we were able to demonstrate improvement in our classification based on the system. And we can also see that we are using the LIRAS classification as it was intended, and then we are meeting the benchmarks that were published. So we can congratulate the GI radiologists and say that looking at this data at scale, we're doing a great job. So that's a success. And then lastly, I want to talk about timelines. So that's what I started with. So let's think about whether we can actually reconstruct these. So here we are starting with a transplant date on day 0, and then we're working backwards in time in days. And we can see this patient had a CT and a couple of MRIs. At least that's what happened in Addenbrooke's. That's what we have data for. And then based on the data from the reports, we can start seeing what kind of treatments they had before. So we can see, oh, they had an ablation at some point between this MRI and CT, and then they had an embolization and a resection even before they came to Addenbrooke's, because there is evidence of it in the radiology report. Furthermore, we can start to see what lesions they had at each of these scans. So they started off with one LR4 lesion, that's probably what they were referred for. But then they also developed an LR3 lesion. And then you can see there is a LRTR non-viable lesion, so treated lesion, and that corresponds very nicely to the fact we think there was an ablation in that interval. Now, what we don't really know at this moment is how these are connected to each other. And I think if you ever have reported MRI liver, you know that figuring out which lesion is which is not always easy, and doing this just from the report and not from the imaging is a challenge. So I think this is one of the future tasks that we can address. At the moment, we just know what happened at each time point. We don't necessarily know how they were connected. However, we can then add some other information to it from liver transplant assessment reports. So here, it's the same structure of a timeline. We know when the liver transplant assessment happened, and we also can see information about those 3 treatments. But now we can pinpoint an exact date when that happened. So we can see there is complementary data with using more than one report type. So we could only look at radiology reports, but actually we are always going to find out more information that complements itself through looking at multiple sources. It's also a nice kind of internal validation that this was reported in both of these. It's kind of a corroboration exercise. So this is based on the data I extracted manually, and then this is the data extracted by the large language model. And it's almost perfect. It's not quite perfect. There are some more lesion kind of numbers that were extracted. So this bar here is higher, but the lesion types that were extracted are mostly correct. It's actually very, very high accuracy. So we, again, can acknowledge that and do research in terms of time series on the types of liver lesions that these patients have at each point in time. And, well, that's another task for the future. So in conclusion, I think that large language models will allow us to do large-scale research and audit in a scale that we just couldn't do before. And I think it will be much faster. I think it's a great opportunity to look at real-world data. They are definitely not perfect. There are mistakes there, and they do need supervision. And I think they do need this kind of check that it's actually extracting what you're expecting it to do. There are new papers now that show that it matters who writes the prompt. So doctors write better prompts than people who are untrained. I think you need to know what to expect from these reports so you don't ask questions that simply cannot be answered, because then LLMs will hallucinate and they will just make up stuff. And lastly, we were able to do this because all the liver transplant patients signed a consent form that they agree to share the data for research. So we extracted all of these reports from Addenbrookes onto a university server. We were able to download an open source model and run the inference. And should this be more of the case, now that we have this technology, should we be implementing this at scale? Maybe everyone who comes into hospital, people who have a CT. In my experience, consenting patients, they're often more than happy to share their data. And I know we've been having a chat that there are new platforms coming into Addenbrookes that might make this possible, which is really exciting. And thank you very much for your attention. Thank you to my funders. And